Welcome to the deep dive. Imagine this. A microscopic passenger, potentially carried by, what, a third of the world's population?
That's the figure, yeah.
Quietly influencing everything from, well, our brains maybe, to our eyes. This isn't science fiction. It's the real story of Toxoplasma gondii.
Absolutely.
Today, we're taking a truly deep dive into Chapter 228 on Toxoplasma infections. You've brought us some really comprehensive source material.
Yes, it's a solid medical text. Very authoritative.
And our mission, like always, is to really pull out every important nugget of knowledge, every insight, to help you truly master this complex topic. We want you to understand it with the kind of depth and clarity you'd expect from an expert in this field.
That's the goal. We're drawing directly from this text to give you a really foundational, but also detailed understanding of this, fascinating parasite, Toxoplasma gondii. It's an obligate intracellular parasite, which is key.
Right.
We'll cover its definition, unpack its really quite intricate life cycle, explore how it spreads, what it actually does to the body, the pathogenesis.
How we diagnose it?
Exactly. Diagnosis, treatment, and really importantly, prevention. How can we stop it?
So get ready for maybe some aha moments here, because we're going way beyond just the basics. We'll explore the subtleties, some surprising facts maybe, and the broader implications of an infection that, well, often just flies under the radar.
It really does, despite being so common.
So let's unpack this. Let's start right at the beginning, defining toxoplasmosis.
Yeah.
What exactly is this organism? What makes it such a, well, pervasive invader?
Okay, so at its core, toxoplasmosis is the infection caused by Toxoplasma gondii. And the term you really need to grasp is obligate intracellular parasite.
Okay, obligate intracellular, meaning?
It means it has to live inside a host cell. It literally cannot survive or replicate on its own outside of a living cell. It must invade and live inside our cells to complete its life cycle and, cause infection.
So it's totally dependent on us or other hosts.
Completely dependent. This fundamental characteristic, this reliance on a host, is absolutely key to understanding its biology, why it behaves the way it does inside the body. It's not free living. It's a master of, getting inside cells.
And the scale of it. You mentioned the statistic earlier, up to a third of the world's population potentially latently infected. That's staggering.
It is. Think about that. Billions of people, potentially, often completely unaware they're carrying it. This isn't some rare thing. It's incredibly widespread, silently carried.
A silent epidemic, almost.
You could say that, yeah. And what's really interesting is how varied its clinical presentations can be. For most people with healthy immune systems, we call them immunocompetent. An acute infection, one they get after birth, is typically asymptomatic. No symptoms at all.
So they wouldn't even know they'd been infected.
Exactly. This silent nature is precisely why it's so easy to miss, and why so many people live their whole lives with a latent infection without ever knowing. It really tells you that, for most of us, our immune systems are doing a remarkable job keeping this parasite in check.
But it's not always silent, right? Even in people with healthy immune systems, some people do get sick.
That's correct. Some immunocompetent individuals can develop symptoms. These might be systemic, sort of body-wide symptoms, or ocular, specifically affecting the eyes. And here's a really crucial point, tying back to its nature. Acute infection is generally thought to lead to lifelong chronic persistence of the parasite.
Lifelong.
Yeah, typically in the form of these little dormant cysts within the host's tissues. Once it's in, it generally stays with you in this latent form.
Okay, so that's the often silent acute phase. What about the classic, more severe presentations we sometimes hear about, especially in vulnerable people?
Right. The most dramatic and severe presentation is encephalitis. That's inflammation of the brain. And we see that predominantly in immunocompromised individuals.
Like people with HIV?
Primarily, yes. Especially before effective antiretroviral therapies were widespread. What happens is a latent infection, that silent passenger we talked about, reactivates because their immune system just isn't strong enough anymore to keep it contained.
So it highlights how vital a healthy immune system is.
Absolutely critical. Without it, the parasite can reactivate and cause significant, often devastating damage.
And beyond encephalitis, the source material mentions a whole range of other things Toxoplasma can do. What other parts of the body can it hit?
It's quite diverse, really, because the parasite can spread throughout the body. You can see lymphadenopathy, which is just swollen lymph nodes.
Okay.
Encephalitis, as we mentioned. Myocarditis, which is inflammation of the heart muscle. Pneumonitis, lung inflammation. and retinitis, inflammation of the retina in the eyes.
So it can really get around.
It demonstrates its wide tropism, its ability to infect lots of different tissues.
Now, something particularly concerning, and it really highlights the long-term impact, is congenital toxoplasmosis. When newborns are affected, how does that happen, and what are the potential outcomes?
Yeah, congenital toxoplasmosis results from transplacental passage. So parasites pass from an acutely infected mother, cross a placenta to the fetus. The mother gets the infection during pregnancy. And what makes this so challenging is that newborns might seem perfectly fine at birth. They might be asymptomatic, no obvious signs.
But the problem develops later.
Often, yes. Many of these children later develop significant and often delayed signs and symptoms. Things like chorioretinitis, a really severe inflammation of the back of the eye, the choroid and retina, which can impair vision,
Wow.
strabismus, which is crossed eyes, epilepsy, and psychomotor retardation, meaning delays in mental and motor development. It really underscores the long-term, often hidden impact of getting this infection before birth. Makes early detection absolutely vital.
It's a real reminder that even if a baby looks healthy, the danger might still be lurking. The source also mentioned outbreaks, like food or waterborne.
Indeed. Outbreaks linked to environmental contamination, like contaminated water supplies or food sources, can lead to clusters of acute disease. And typically these outbreaks present as a spike in cases of chorioretinitis, that eye inflammation, which reinforces the link between environmental exposure and ocular disease.
Okay, let's really unpack this life cycle of Toxoplasma gondii. The outline calls it a masterclass in adaptation, and honestly, after hearing about how widespread it is and the different ways it affects people, I can see why. We need to really grasp how it moves between hosts to be so successful.
Absolutely. Understanding the life cycle is foundational.
Okay.
It explains its resilience, its pervasiveness. So fundamentally, there are two primary stages that are infectious to humans.
Okay, two main forms we can catch.
Right. First, you have tissue cysts. These contain a slower replicating form of the parasite called bradyzoites. Think of them as dormant clusters.
Okay, bradyzoites and cysts, where are these found?
They're primarily found in the central nervous system, the brain, and spinal cord, and in muscle tissue of infected animals. Humans typically get these by eating insufficiently cooked meat.
Undercooked meat, like what?
Particularly lamb and pork are often cited, but also venison, even ground beef if it's not cooked through properly. This is a really significant route of infection, especially in developed countries where meat consumption is common.
So that medium rare steak or undercooked pork chop could be a source.
Got it. What's the other key stage?
The second stage is the sporulated oocyst. These contain sporozoites. Oocysts are the really hardy, environmentally resistant forms. They're the product of the parasite's sexual cycle.
Sexual cycle.
Yes, and this is fascinating. The sexual cycle happens only in the intestines of felines, cats.
Only cats.
Domestic cats.
Domestic cats are the main definitive host, yes. They're where the parasite completes its sexual reproduction. Humans then acquire these oocysts by ingesting food or water contaminated with infected cat feces.
Okay, so cat feces in the environment, like contaminated soil in a garden.
Exactly. Or contaminated soil, untreated drinking water sources, maybe unwashed vegetables grown in contaminated soil. This explains why we see those waterborne outbreaks sometimes.
Okay, so the cat is the definitive host where sexual reproduction happens. They shed these oocysts. Then intermediate hosts, birds, mammals, humans, pick them up from the environment.
Correct. Either by ingesting the oocysts from soil or water.
Or, as you said, by eating the tissue cysts in undercooked meat from an infected animal.
Precisely. Now let's trace what happens once these infectious forms actually get inside the human body. So upon ingestion, whether it's bradyzoites from cysts or sporozoites from oocysts, our digestive processes release them.
Okay.
And here's a neat adaptation. The bradyzoites are remarkably resistant to pepsin, one of our main stomach enzymes. This helps them survive the acidic stomach environment and make it into the intestine.
Clever.
Once they're released in the intestine, they quickly invade intestinal epithelial cells or other cells nearby in the gut, and they transform. They change into a highly active, rapidly dividing form called tachyzoites.
Tachyzoites. Tachy meaning fast. So this is where they get really active and cause problems.
Exactly. Tachyzoites are the rapidly dividing, tissue-damaging stage. These are the invasive forms. They actively penetrate and replicate inside almost all nucleated mammalian cells.
Almost all cells.
Except red blood cells, which don't have a nucleus.
Yeah.
Inside the host cell, they create this little protective bubble around themselves called a parasitophorous vacuole.
A little home inside our cells?
Kind of. And they multiply like crazy inside there. Once they reach a certain number, a critical mass, Specific signals trigger them to burst out. They egress, destroying the host cell in the process.
Ah, so that's the damage.
That destructive process, the cell death, and the resulting inflammation is what directly causes the clinical symptoms we see during the acute infection phase.
It's like tiny explosions happening at a cellular level. How do they spread from the gut to the rest of the body then?
They can disseminate in a couple of ways. They can travel as free parasites just floating in the bloodstream. Or, and this is quite clever, they can infect immune cells, like macrophages.
The cells that are supposed to eat them.
Right. They infect them and use them as Trojan horses. These infected immune cells then carry the parasites through the bloodstream or lymphatic system to distant organs, the brain, muscles, eyes, everywhere. Their invasive nature also lets them actively push through barriers, like the linings of blood vessels or tissues, giving them access to pretty much anywhere in the body.
That is a terrifyingly efficient invasion strategy. But our bodies fight back, don't they? How does the immune system manage this and lead to that chronic latent stage you mentioned?
You're right. The body mounts a robust defense. Most of those rapidly dividing tachyzoites are eventually eliminated by the host's powerful immune response, both antibodies, which is the humoral response, and specialized immune cells, the cell-mediated response.
Okay.
But after about 7 to 10 days of this systemic tachyzoid activity, the parasite adapts again. Tissue cysts containing those slow-replicating bradyzoites start to develop.
Ah, the dormant stage cysts.
Yes. And these cysts primarily set up shop, if you will, within the central nervous system and muscle tissue. That's why neurological or muscular issues can be long-term problems. This cyst formation effectively completes the asexual part of the life cycle within the human host.
And these cysts are the reason for the reactivation we talked about in immunocompromised people.
Precisely. In someone whose immune system is weakened, say, due to HIV/AIDS or immunosuppressive drugs, active infection usually flares up because these cysts spontaneously rupture, releasing the bradyzoites.
And the weakened immune system can't stop them.
Exactly. The released bradyzoites quickly transform back into those destructive tachycytes, and the compromised immune system just can't contain the onslaught, leading to severe disease like TE.
You mentioned earlier the oocysts, the ones from cats, are incredibly hardy. Can you elaborate on that? Why is their environmental resilience so significant?
Absolutely. When cats shed oocysts in their feces, they're initially not infectious, they're unsporulated.
Okay.
But after just 2 or 3 days of exposure to air and moisture at normal temperatures, they sporulate, they mature. This process produces 8 infectious sporozoites inside each oocyst.
And these sporulated ones are the tough ones.
Incredibly tough. They have a very robust outer shell. This allows them to remain viable, meaning infectious, for many years, potentially decades in soil or water.
Wow, years.
This exceptional durability explains why contaminated soil remains a risk factor for so long, and why waterborne outbreaks can happen years after initial contamination. They're a silent, persistent threat in the environment.
That persistence is huge for public health. And speaking of geography, the source mentioned significant strain variations. Does the type of T. gondii affect how sick people get, how virulent it is?
It absolutely does. This is a really important point for doctors and researchers. In the Northern Hemisphere, places like the US, Canada, Europe, the T. gondii strains are mostly of 3 common genotypes.
Okay.
But here's a key difference. Strains found in South and Central America are often much more virulent. They're frequently what's called a type I virulent genotype or other atypical, more aggressive genotypes.
More virulent meaning more likely to cause severe symptoms.
Exactly. Significantly more likely to cause symptomatic disease. Often, this presents as severe ocular posterior uveitis, that serious eye inflammation we talked about, which can threaten vision.
Even in healthy people.
Yes, even in people with normal immune systems. Severe systemic disease, like sepsis, high fevers of unknown origin, severe pneumonia. These have been reported with these South American strains. So a detailed travel history becomes critical. Asking, where have you lived or traveled, can be a key diagnostic clue, especially for South or Central America.
That makes sense. It changes the whole picture.
Right, and while the data for Africa is a bit less extensive, studies show T. gondii infection is common there too, and strain diversity likely plays a role in the types of disease seen.
Okay, so geography matters. Let's move on to epidemiology. Where is Toxoplasma most common? What does the seroprevalence, the antibody data tell us?
Seroprevalence, which shows us how many people have been exposed, varies a lot. It depends heavily on the specific location and the age of the population being tested. Generally, hot, dry climates tend to have lower prevalence.
Why is that?
Probably because those conditions are less favorable for the oocysts surviving long-term in the environment. They need some moisture.
Makes sense.
In contrast, places like the United States and most European countries typically see seroprevalence increasing with age. The longer you live, the more chance you've had to encounter it.
What are the trends in the U.S. specifically? Is it going up or down?
Actually, in the U.S., we've seen a steady decrease over time, which is good news. A big survey from 2011-2014 showed about 11% of people over age 6 had antibodies. Interestingly, though, people born outside the U.S. tend to have higher rates, likely reflecting higher exposure in their home countries.
And how does that 11% compare globally? You mentioned South America has more virulent strains. Is prevalence higher there too?
Dramatically higher in many regions. For example, in Brazil, rates as high as 78% have been reported. A very different picture.
Wow, nearly 80% in some areas.
Yeah. But there is a positive global trend. Worldwide, the overall seroprevalence seems to have decreased over the past couple of decades.
Why is that happening?
It's likely due to a combination of factors: increased public awareness about foodborne infections in general, and probably better food safety practices being implemented more widely. So public health efforts seem to be making a difference.
That's definitely encouraging. Okay, let's focus on transmission routes. How do people primarily get infected? What are the main ways it gets into our bodies?
The vast majority of human infections are thought to happen orally. That's the main route.
Eating or drinking something contaminated.
Exactly. This happens in two main ways. First, by ingesting those sporulated oocysts we talked about that runs from cat feces. These can be in contaminated soil, on unwashed fruits or vegetables, or in contaminated water.
And cats shed a lot of these.
An acutely infected cat can shed an incredible number, up to 100 million oocysts per day. And remember, they're highly infectious and survive for years. So environmental contamination is a major, long-lasting risk.
So gardening without gloves, eating unwashed salad greens, drinking untreated stream water, all potential risks.
Definitely. The other major oral route is ingesting the tissue cysts containing bryozoates.
From undercooked meat.
Right. Undercooking or insufficient freezing of meat, especially lamb, pork, venison, ground beef, is a huge source, particularly in the developed world. The source also mentions drinking unpasteurized goat milk. And interestingly, more recent studies point to untreated water or even shellfish.
Shellfish. How?
Oysters, mussels, clams, they're filter feeders. They pump large volumes of water through their bodies, and if that water contains oocysts, they can concentrate them. So eating raw shellfish from contaminated waters is another potential route.
Fascinating. So it's not just cats and meat. Water, shellfish.
Okay.
Okay. Are there non-oral ways to get it? Ways besides eating or drinking?
Yes, there are. T. gondii can be transmitted directly through blood or organ transplants.
Oh, wow.
It can pass from a seropositive donor, someone who has antibodies, to a seronegative recipient during organ transplantation. Heart, lung, kidney, liver, pancreas transplants are all cited.
So screening donors and recipients is crucial.
Absolutely critical in transplant medicine. Viable parasites can even survive in refrigerated blood used for transfusions, making that a potential, though probably less common, source.
And reactivation is a risk in transplant patients too.
Yes, reactivation of a latent infection has been reported in various transplant recipients, bone marrow, stem cell, liver, as well as in AIDS patients, of course. Patients who have higher antibody levels before transplant might be at higher risk for reactivation after certain types, like stem cell transplants. This really underlines why screening both donor and recipient before transplant is standard practice.
Makes sense. Any other routes?
There's also occupational exposure. Laboratory personnel handling contaminated materials can potentially get infected.
Right, lab safety. Okay. And then there's congenital transmission again, that unique challenge. What are the absolute critical factors that influence whether a pregnant mother passes it to her fetus?
This is where timing is everything. It's crucial to understand. Not all women who get T. gondii during pregnancy will transmit it. Many give birth to perfectly healthy, uninfected babies.
Okay, that's good to know.
The gestational age. The point in the pregnancy when the mother gets infected is the single most critical factor influencing the fetal outcome.
So when she gets infected matters most. How does that work?
If the mother gets infected during the first trimester, the risk of actually transmitting it to the fetus is the lowest, maybe around 15%. But if transmission does happen early on, the disease in the baby is typically the most severe, often major developmental problems.
Okay. Low risk of transmission, but high severity if it happens. What about later in pregnancy?
Conversely, If the mother gets infected during the third trimester, the risk of transmission is much higher, up to 65%, so it's more likely to cross the placenta. But the infant is usually asymptomatic at birth, and the immediate clinical severity tends to be less pronounced.
Higher risk of transmission, but low initial severity.
Right. But, and this is key, even if those babies look fine at birth, they might still have a higher chance of developing learning disabilities or chronic neurological problems later in life, sometimes years or even decades down the line. It really shows the insidious long-term nature of congenital infection.
That's a really important distinction. Earlier infection, less transmission, more severe. Later infection, more transmission, less severe initially. What about women who are already infected before they got pregnant? Are they generally safe?
Yes, that's a major point of reassurance. Women who are seropositive before pregnancy, meaning they had a past infection and already have IgE antibodies, are generally protected against getting an acute infection during pregnancy. They typically do not give birth to congenitally infected babies.
So prior immunity protects the baby.
Pretty much. Reactivation of the mother's latent infection causing congenital transmission is rare, unless the mother herself becomes severely immunocompromised during pregnancy, like having uncontrolled HIV or being on very high-dose steroids.
That's a relief. Is there a recommended waiting time if a woman gets infected shortly before trying to conceive?
Yes, the guidelines suggest there's essentially no risk if the mother's infection occurred 6 months or more before conception. But if it happens less than 6 months before, the risk of transmission increases the closer the infection is to conception. So, women with a documented acute infection are generally counseled to wait at least 6 months after infection before becoming pregnant.
6 months, okay. And is it usually obvious if a pregnant woman gets an acute infection? Does she get symptoms?
Unfortunately, usually not. It's often silent, which is part of the challenge. Only about 20% of women infected during pregnancy actually develop noticeable clinical signs. Often, the first clue is from routine prenatal blood tests showing the presence of antibodies, meaning the infection itself was completely asymptomatic for the mother.
Which makes screening crucial.
Vital, yes, especially in regions with higher prevalence or for women with specific risk factors.
This parasite really is a stealth operator. Let's shift now to pathogenesis. How T. gondii actually invades our cells and interacts with us at a cellular level. How does it cause disease?
It's a sophisticated process.
Mm-hmm.
So once ingested, the parasites, bradyzoites or sporozoites, are released by digestion. Bradyzoites, remember, resist stomach acid and invade the gut lining.
Right.
Inside those intestinal cells, they quickly transform into the invasive tachyzoites. And these tachyzoites don't just stay in the gut, they disseminate, they spread.
Where do they go?
Through the bloodstream and lymphatics, they reach various organs all over the body. Lymphatic tissues, skeletal muscle, heart muscle, the retina, the placenta in pregnant women, and critically, the central nervous system.
Pretty much everywhere. What happens when they get there?
At these sites, they infect host cells, replicate rapidly inside them, and then burst out to invade neighboring cells. This cycle invasion, replication, cell destruction leads directly to the hallmarks of acute infection: cell death and focal necrosis, meaning localized patches of dead tissue. And this damage triggers an intense inflammatory response from the host.
So the damage is direct killing of cells plus the inflammation it causes.
Exactly. That combination causes the pathology and the symptoms during the acute phase.
But in someone with a healthy immune system, the body eventually gets it under control. How does that defense work against such an aggressive invader?
That's right. The immunocompetent host mounts a powerful, multi-layered defense. Both antibodies, the humoral response, and specialized immune cells, the cell-mediated response, work together to control the infection. And remember, the virulence can vary by strain, like those South American strains being more aggressive.
Okay, so what are the specific weapons the immune system uses against those tachyzoids?
Several key mechanisms. First, the body produces parasiticidal antibodies that can directly help kill the parasites, especially when combined with complement proteins in the blood. Second, immune cells called macrophages get activated. When they engulf parasites coated with antibodies, they can kill them using reactive chemical intermediates.
Okay, antibodies and activated macrophages. What else?
Third, there's the production of a critical signaling molecule, a cytokine called interferon gamma, IFNR. IFNR is essential for activating other immune cells and controlling parasite replication. And fourth, the immune system stimulates CD8 plus cytotoxic T lymphocytes, often called killer T cells.
Killer T cells, what do they do?
These cells are like guided missiles. They specifically recognize infected host cells and kill them directly, eliminating the parasite's hiding place. They can also kill parasites that are outside cells.
A very targeted attack. And this immune control is what leads to the formation of those dormant cysts.
Yes. As the immune system clears out most of the actively replicating tachyzoites, typically around 7–10 days into the infection, the parasite transitions. Tissue cysts containing the slow-growing bradyzoites start to form, mainly in the CNS, muscle, and retina. This is the shift to the chronic latent stage.
And toxoplasma isn't just passive in this stage, right? You mentioned manipulation.
Exactly. It's quite sophisticated. The parasite actively secretes molecules into the infected host cell. These molecules can actually modulate the host cell's gene expression, change its metabolism, and even dampen down certain immune responses locally to help the cyst survive. It's a true silent operator, subtly influencing its environment.
Wow. And I recall reading that the old idea was these cysts were totally invisible to the immune system, but maybe that's changing.
That's a great point, reflecting how our understanding evolves. It used to be thought cysts were completely immune evasive, just sitting there ignored. But recent studies, mostly in mice so far, suggest that certain immune cells, like those CD8 plus T cells and specific types of macrophages, can actually recognize and kill some of these cysts in vivo.
So the battle might still be simmering even in the chronic phase.
It seems more dynamic than we thought. Some cysts definitely persist, maybe lifelong, but the immune system might still be exerting some level of control or surveillance. It might even depend on the host genetics, how well they can clear cysts. It's an active area of research.
So if the healthy host has these impressive defenses, what goes wrong in immunocompromised individuals or in a developing fetus? Why is the outcome so different?
In those situations, the host simply lacks the necessary fully functional immune components to control the tachyzoite replication and spread. Whether it's an immature immune system in a fetus or a depleted one in an AIDS patient, the defenses are down.
And that allows the tachyzoites to run rampant.
Precisely. This altered immune state allows the tachyzoites to persist, replicate unchecked, and cause progressive, widespread tissue destruction in affected organs. This leads to those severe outcomes like necrotizing encephalitis, brain tissue death, severe pneumonia, myocarditis, conditions that can be rapidly fatal without treatment.
Which brings us to that really intriguing, maybe controversial idea. The potential link between chronic toxoplasma infection and neuropsychiatric conditions. What's the story there?
Right. It's generally accepted that pretty much everyone infected carries these latent bradyzoid-containing cysts, usually without symptoms. The slow metabolism of these bradyzoids and the potential for cysts to occasionally rupture and reform likely explains the lifelong infection and the source of reactivation in the immunocompromised.
Okay.
Now, the neuropsychiatric link, it's definitely a hypothesis that's generated a lot of interest in research. The idea is that this persistent chronic infection might be a contributing factor to conditions like schizophrenia, bipolar disorder, maybe even subtle personality changes.
A contributing factor. What's the evidence? Is it strong?
Well, in rodent studies, the evidence is quite compelling. Chronic T. gondii infection in rats and mice clearly affects their behavior. Famously, it makes them less afraid of cats, their natural predators.
The fatal attraction phenomenon.
Exactly. It's seen as a way the parasite might manipulate the intermediate host to increase its chances of getting back into a cat, its definitive host. Now, translating that directly to complex human psychiatric disorders is a big leap, and the evidence in humans is more correlational and debated.
So, intriguing but not proven in humans yet. What about the mechanism? How could a parasite influence the brain like that?
One leading hypothesis involves epigenetics. The idea is that the parasite might subtly remodel the host's epigenome, making changes to how genes are expressed in brain cells without altering the actual DNA sequence. These epigenetic changes could potentially lead to long-lasting alterations in brain function, contributing to neuropsychiatric syndromes. But again, this is an active area of research, trying to connect the dots between infection, immune response in the brain, epigenetic changes, and behavior. It's a truly mind-bending concept.
Absolutely. The idea that a common parasite could subtly rewire our brains. Fascinating and a bit unsettling. Okay, let's shift to pathology. What does the disease actually look like under the microscope? What's the physical evidence of this invasion?
Microscopically, you see the direct results of the parasite's activity. Those replicating tachyzoites cause host cell death and focal necrosis, little areas of dead tissue. This damage triggers an intense inflammatory response, mostly mononuclear cells like lymphocytes and macrophages rushing to the site.
Can you see the parasites easily?
The tachyzoites themselves are often hard to spot with standard stains because they're small and move between cells quickly. But special techniques like immunofluorescent staining using antibodies against Toxoplasma can light them up and reveal their presence within the lesions.
What about the cysts?
The bradyzoite-containing cysts, once they're mature, are different. They cause very little inflammation around them. They're relatively immunologically quiet, hiding out in the tissue matrix, especially the brain, until they rupture. Masters of evasion in that chronic stage.
Hiding in plain sight, almost. What about specific organs? Swollen lymph nodes are common in acute infection. What do they look like microscopically?
Yeah, lymph node biopsy during acute infection often shows characteristic features. You see follicular hyperplasia, the follicles where immune cells gather are enlarged. You also see these irregular clusters of tissue macrophages with pinkish cytoplasm. Granulomas, those organized balls of immune cells you see in TB, are rare in toxo.
Can you confirm the diagnosis from the biopsy?
While you usually don't see the taxoids directly with standard stains, you can confirm their presence. Historically, they'd inject the tissue into mice and see if the mice got sick. Nowadays, PCR amplification of Toxoplasma genes from the biopsy tissue is highly effective and sensitive for confirming active infection in the lymph node.
What about the eyes? Ocular toxo seems so common and serious.
In the eye, you see infiltrates of immune cells, monocytes, lymphocytes, plasma cells, creating these multifocal lesions. In the back of the eye, the posterior chamber, you can see granulomatous lesions and retinochoroiditis, inflammation of the retina and the layer underneath, the choroid, especially after an episode of acute necrotizing retinitis.
Can it cause other eye problems too?
Yes, complications can include inflammation of the iris and ciliary body, uriticolitis, cataracts, and glaucoma. And it's worth repeating. T. gondii is the most common cause of posterior uveitis in immunocompetent people in many parts of the world. That's a huge impact on vision health.
And the CNS, the brain, where it causes such devastating disease in AIDS patients. What's the pathology there?
In the CNS, you can see both focal, localized, and diffuse, spread out, meningoencephalitis inflammation of the brain tissue and its coverings. There's clear evidence of necrosis, tissue death, and microglial nodules, which are little clusters of activated brain immune cells.
Are the lesions different in AIDS patients compared to others?
In patients without AIDS who get CNS toxo, the lesions tend to be smaller, more diffuse, often with immune cells cuffing around blood vessels. In the AIDS population, the inflammation can be more intense, sometimes including other types of white blood cells like neutrophils, alongside the usual suspects. And you frequently find those bradyzoite cysts right at the edge of the necrotic areas.
And you mentioned art has reduced this.
Yes, thankfully. Widespread use of effective antiretroviral therapy has significantly decreased the incidence of Toxoplasma encephalitis in developed countries, but it remains a major concern in resource-limited settings without easy access to diagnosis and treatment.
What about the lungs and heart? They can be involved too, right?
Yes, particularly in severe cases, often in AIDS patients. Autopsy studies show lung and heart involvement in 40–70% of AIDS patients who die from toxoplasmosis. In the lungs, you can get interstitial pneumonitis inflammation of the lung tissue itself. The walls between the air sacs get thickened, swollen, infiltrated with immune cells. You can actually find taxoites and cysts within the lung tissue.
Can that be confused with other lung infections?
Yes, it can mimic other opportunistic pneumonias like PCP, pneumocystis pneumonia. Sometimes bacterial pneumonia can occur on top of it. In the heart, you can find cysts and parasites in the heart muscle, causing focal necrosis, inflammation, and damage to muscle cells. Pericarditis, inflammation of the sac around the heart, can also occur.
And the GI tract. It starts there, but does it cause much direct damage in the gut itself?
Usually not severe direct pathology in humans, surprisingly. While invasion starts there, clinically significant GI disease is rare. The source mentions a severe inflammation of the ileum in animal models, suggesting the potential exists, but it's not a common feature of human disease, except perhaps in very widespread, disseminated infections.
So it can really spread anywhere in severe cases.
Pretty much. In disseminated infections, especially in AIDS patients, you can find it in skeletal muscle, pancreas, stomach, kidneys. You see necrosis, inflammation, sometimes taxoites. This can lead to secondary problems like pancreatitis, myositis, muscle inflammation, even kidney inflammation, glomerulonephritis. It really highlights how devastating it can be when the immune system is compromised.
It truly underscores the power of the immune system. Let's talk more about that immune response. How exactly does the body fight this intricate battle, and what specifically goes wrong when immunity fails?
Okay, so when Toxoplasma first enters, usually through the gut, it triggers an immediate mucosal immune response right there at the lining. This includes producing specific antibodies called secretory IgA, which try to block the parasite early on. In fact, detecting serum IgA antibodies against a key tachyzoid surface protein P30asAG1 is a useful early marker for acute or congenital infection.
So IgA is the first responder antibody. What about the more common IgG and IgM?
The body quickly ramps up production of both IgM and IgG antibodies in the blood. IgM usually appears first, indicating recent infection, while IgG rises a bit later and typically persists for life, indicating past exposure. Interestingly, in congenitally infected infants, you might see specific IgG patterns or elevated IgM. The IgG antibodies produced are actually capable of killing the parasite in vitro if complement proteins are present. That's the basis of the classic Sabin-Feldman dye test for diagnosis.
But the source really emphasizes cell-mediated immunity as the main player, right? The cells doing the heavy lifting.
Absolutely. Cell-mediated immunity is the major protective response against intracellular parasites like Toxoplasma. Macrophages are key players. When they engulf parasites coated with antibodies, opsonization, they become activated and can kill them internally.
But you mentioned the Trojan horse mechanism earlier.
Right, that's the flip side. If the parasite actively invades macrophages or other immune cells like dendritic cells without being opsonized, it can survive inside and use those cells to travel around the body. It's a clever evasion tactic.
So how do other cells fight back? T cells.
T cells are absolutely crucial. You get activation of both CD4 plus helper T cells and CD8 plus killer T cells that specifically recognize Toxoplasma antigens. CD4 cells help orchestrate the response, releasing signaling molecules called lymphokines that boost the activity of other immune cells, including natural killer NK cells. CD8 cells, as we discussed, directly kill infected host cells, eliminating the parasite's hiding place.
The specific chemical signals are important.
Yes. Toxoplasma strongly induces what's called a Th1 immune response profile. This involves key cytokines like IL-12, which helps activate T cells, and especially interferon gamma, IFNO, which is critical for controlling parasite growth within cells. There's also a balancing act. A Th2 response involving cytokines like IL-4 and IL-10 helps regulate the inflammation so it doesn't cause too much collateral damage. Other cytokines like IL-18, IL-7, and IL-15 also play roles in boosting the IFN response during both acute and chronic phases. It's a complex, regulated network.
An incredibly complex dance. Now, what specifically breaks down in this immune response in immunocompromised patients, like those with AIDS?
This is the critical failure point. In AIDS patients, especially those with reactivation toxoplasmosis, their T cells don't function properly. Specifically, they often fail to produce adequate amounts of both IFNO and another key cytokine, IL-2.
So the main chemical signals are missing. Essentially, yes. Without enough IFNS and IL-2, the cell-mediated response falters, macrophages don't get properly activated, and killer T cell function is impaired. This allows the parasite to replicate relatively unchecked. This failure is most pronounced when the CD4 plus T cell count drops very low, typically below 100 cell, which is when TE usually develops. The loss of T cell help and direct killing ability is devastating. And antibody levels aren't helpful in diagnosing reactivation in these patients.
Correct. While almost all AIDS patients with TE will have IgG antibodies from their past latent infection, the level of antibodies doesn't reliably indicate active disease or reactivation. IgM is usually negative. So while a positive IgG tells you they're at risk, it doesn't confirm active TE. Conversely, a truly negative IgG makes TE very unlikely, although low or borderline results can occur.
So the immune system is absolutely central. Let's delve into the clinical manifestations now. How does toxoplasmosis actually present itself in different people, starting with healthy, immunocompetent individuals?
Okay. In people with intact immune systems, acute toxoplasmosis is overwhelmingly asymptomatic. Maybe 80–90% of infected adults and children never even realize they had it. It just passes silently.
Which makes diagnosis hard, especially in pregnant women, you mentioned.
Exactly. They might have no symptoms to alert them or their doctor.
So when it does cause symptoms in healthy people, what's the most common thing they notice?
The most common symptomatic presentation is lymphadenopathy, swollen lymph nodes. Usually in the neck, cervical nodes, they might be single or multiple nodes, typically not painful, feel discrete, and can vary from soft to firm.
Just swollen glands in the neck?
Mostly neck, but can also involve nodes behind the head, suboccipital, above the collarbone, supraclavicular, in the groin, inguinal, or even inside the chest, mediastinal. Generalized swelling in multiple areas occurs in maybe 20–30% of symptomatic cases.
Do they feel sick otherwise?
About 20–40% of those with lymphadenopathy mostly get other symptoms like headache, malaise, just feeling generally unwell, fatigue, maybe a low-grade fever, usually under 140 degrees atmosphere at 40 degrees C.
Are there less common, but maybe more serious, things that can happen even in healthy people?
Yes, though less frequent. Some might get muscle aches, myalgia, sore throat, abdominal pain, a specific type of rash, maculopapular, or even mild confusion or meningitis-like symptoms, meningoencephalitis. Rarely, really severe complications can occur, like pneumonia, myocarditis, heart inflammation, encephalopathy, brain dysfunction, pericarditis, heart lining inflammation, or polymyositis, muscle inflammation.
How long does it usually last if someone does get symptoms?
The general symptoms, fever, fatigue, usually resolve within several weeks on their own. The lymphadenopathy, though, can sometimes persist for months.
And diagnosis can be tricky.
Very tricky. The source mentions one outbreak where only 3 out of 25 patients were correctly diagnosed initially. The symptoms are quite specific. That's why if toxo is suspected, doing the blood test for antibodies, serology, is important before jumping to something invasive like a lymph node biopsy.
And we need to remember the geographic strain variation here too, right? Travel history matters.
Absolutely critical. Those more virulent strains from South America can cause more severe disease like the eye problems, pneumonia, even a sepsis-like illness, even in immunologically normal people. So always ask about travel and residence.
What about routine lab tests? Anything specific show up?
Usually not much. Maybe a slight increase in lymphocytes, a slightly elevated sedimentation rate, a general marker of inflammation, maybe a minimal rise in liver enzymes. If there's brain involvement, CSF might show increased pressure, more mononuclear cells, slightly higher protein, but PCR on CSF isn't very sensitive.
Okay, let's pivot to immunocompromised patients, especially those with AIDS. The picture sounds much more severe there.
It is. Patients with AIDS or those on strong immunosuppressive drugs for other reasons, like cancer treatment, organ transplants, certain autoimmune therapies like anti-TNF drugs, are at the highest risk.
And it's mostly reactivation of latent infection.
Over 95% of Toxoplasma encephalitis, TE, cases in AIDS patients are due to reactivation. It typically flares up when their CD4 count, that key immune measure, drops below 100.
And it's life-threatening.
Rapidly fatal if not treated. Accurate diagnosis and starting therapy quickly are absolutely crucial. Before effective ART, TE was a leading cause of death and neurological disability in AIDS. It can still be the first major illness that leads to an HIV diagnosis in someone who wasn't previously aware they had HIV.
What are the classic signs and symptoms of TE in this group? Mostly brain-related.
Primarily CNS, yes. Over half have clear intracerebral involvement. It can range from subtle, non-focal issues like confusion or lethargy to very specific focal deficits.
Like what kind of focal problems?
Common symptoms include altered mental status confusion, drowsiness in about 75%. Fever is common, but not universal, 72%. Seizures occur in about a third. Headaches in over half. And focal neurological signs in about 60%.
What kind of focal signs?
Things like motor weakness or paralysis on one side, hemiparesis, problems with cranial nerves affecting facial movement or vision, movement disorders like tremors or jerky movements, problems with coordination, dysmetria, visual field loss, difficulty speaking, aphasia. It often starts diffusely and progresses to more focal problems.
And this is due to the brain inflammation.
Yes, the necrotizing encephalitis, direct tissue destruction by the parasite, plus secondary effects like inflammation of blood vessels, vasculitis, swelling, edema, and bleeding, hemorrhage in the brain. The onset can be slow, over weeks, or quite sudden and dramatic.
Where in the brain do these lesions typically occur?
They can be anywhere, but common spots include the brainstem, the basal ganglia, deep brain structures involved in movement control, the pituitary gland, and the junction between the gray matter cortex and the white matter underneath, corticomedullary junction.
And the location determines the specific symptoms.
Exactly. Brainstem lesions might cause cranial nerve problems or ataxia. Basal ganglia involvement could lead to hydrocephalus, fluid buildup, or those movement disorders. It's important to note toxo usually causes encephalitis, brain tissue inflammation. Direct inflammation of the meninges, the coverings, is less common. And CSF tests are often not very helpful. Maybe slight increases in cells or protein, but nothing specific.
Given the state of these patients, telling TE apart from other brain problems must be a huge challenge.
Absolutely critical. The differential diagnosis is broad and includes other opportunistic infections like herpes encephalitis, cryptococcal meningitis, progressive multifocal leukoencephalopathy, PML caused by JC virus, as well as primary CNS lymphoma, a type of brain cancer more common in AIDS. They can all present similarly and have similar appearances on scans sometimes.
Can toxo affect other parts of the body in AIDS patients too?
Yes, definitely. Autopsy studies show widespread involvement is common. Lungs, GI tract, pancreas, skin, eyes, heart, liver can all be affected. Toxoplasma pneumonia can be mistaken for PCP and progress rapidly to respiratory failure. Heart involvement is usually asymptomatic, but can occasionally cause severe heart failure or tamponade, fluid buildup around the heart. It's a devastating multisystem infection when the immune system fails.
Let's revisit congenital infection, the clinical side after birth. How common is it, and what's the long-term outlook, especially if treated?
Estimates suggest maybe 400 to 4,000 newborns in the U.S. are affected each year. Remember, the mother's infection is usually silent. The parasite crosses the placenta and infects the fetus.
And the later in pregnancy the infection occurs, the less severe it is initially.
Generally, yes. As gestation proceeds, transmission becomes more likely, but the immediate clinical severity tends to decrease.
But delayed problems are still a major concern, even decades later.
Absolutely. Even if a baby seems perfectly fine at birth, the persistent infection can reactivate and cause clinical disease, most often chorioretinitis, that eye inflammation many years, even decades later.
What factors predict a worse long-term outcome?
Things like delays in diagnosis and starting treatment, complications around birth like lack of oxygen or low blood sugar, severe visual impairment from the start, untreated hydrocephalus, and high pressure inside the skull.
But treatment helps significantly.
Hugely. This is the hopeful part. With appropriate, timely, and sustained treatment, usually for about a year, upwards of 70% of children with congenital toxoplasmosis can have normal developmental, neurological, and eye outcomes long-term. Early intervention is key.
That really underscores the importance of diagnosis and treatment. Now let's focus on ocular infections specifically. It seems prominent across the board.
It really is. T. gondii is estimated to cause about 35% of all cases of chorioretinitis in places like the U.S. and Europe. That's a major cause of posterior uveitis.
And our understanding of when people get ocular toxo has changed.
Yes. It used to be thought that most ocular cases were late manifestations of congenital infection. But now we recognize that acquiring the infection after birth, often through environmental oocyst exposure, like those waterborne outbreaks, is a common cause of ocular toxo, even in immunocompetent adults.
What symptoms do people typically report with eye involvement?
Usually things like blurred vision, scotoma, blind spots, photophobia, sensitivity to light, and eye pain. If the macula, the central part of the retina, is involved, it can cause permanent loss of central vision. It can also affect eye muscle coordination, leading to strabismus.
And eye exams are crucial for newborns.
Essential if congenital infection is suspected. The disease course often involves episodic flare-ups of inflammation, which progressively damage the retina and can lead to complications like glaucoma over time.
What do the lesions actually look like to an ophthalmologist?
Active lesions often look like yellow-white fluffy cotton-like patches with hazy borders due to the inflammation. As they heal, they become more distinct white scars, often with black pigment spots within them. They're usually near the back of the eye, sometimes single, often multiple. Congenital lesions might look different, sometimes showing large areas of scarring from birth, but surrounded by healthy retina.
Is it different in AIDS patients?
Yes, in AIDS patients, the retinal lesions are often much larger, more destructive, with diffuse necrosis, and you can actually see both tachyzoites and cysts in the lesions. Sometimes eye inflammation can even be the first sign of prodrome before someone develops TE.
Okay, this brings us to diagnosis. With such varied presentations, how do we actually confirm Toxoplasma infection? What are the tools?
There are several approaches. You can try to culture the parasite, but that's usually only done in specialized research labs. Serologic testing, looking for antibodies in the blood, is the most common routine method. And then there's PCR, looking for the parasite's genetic material, which is really the mainstay for detecting it directly in tissues or fluids.
What about isolating the parasite directly from blood or tissue?
You can isolate T. gondii from blood or other fluids by injecting the sample into mice and seeing if they get infected, or checking the mice for antibodies later. But interpretation's key here.
How so?
Finding the parasite by isolation or PCR in body fluids like blood or amniotic fluid usually means acute active infection. But finding it in a tissue biopsy might just mean latent cysts are present from a past infection, not necessarily active disease right now. Seeing tachyzoites in tissue confirms acute infection. Seeing only cysts confirms past infection.
Okay, so direct isolation is tricky to interpret. That makes serology sound like the main workhorse. How does that work?
Exactly. Serology is the routine method. Acute infection is generally established by finding both IgG and IgM antibodies against Toxoplasma in the patient's serum at the same time. Finding IgA antibodies also strongly points towards acute infection.
How are these antibodies measured?
There are several good tests for IgG, like the Sabin-Feldman dye test, the classic one, indirect fluorescent antibody, IFA, and ELISIS. Ig antibodies usually become detectable 2-3 weeks after infection, peak around 6-8 weeks, then slowly decline to a lower level that stays positive for life.
And IgM, is that the key marker for recent?
IgM is crucial to measure alongside IgG. Specific IgM tests like the IgM ELISA or IgM ASAGA are recommended because they're sensitive and have fewer false positives. IgA tests are also very useful, sometimes even more sensitive than IgM for detecting congenital infection in newborns.
But you mentioned IgM can persist, so a positive IgM doesn't always mean acute infection.
That's a really important nuance. While a negative IgM with a positive IgG usually means infection was in the distant past, IgM antibodies can persist for over a year in some people. So you can't rely only on a positive IgM to diagnose a recent infection. If things are unclear, specialized labs can do more extensive testing, like antibody avidity testing.
Avidity, what's that?
Avidity measures how strongly the IgG antibodies bind to the parasite antigens. Low avidity suggests a recent infection within the last 3-4 months, while high avidity indicates an older infection. It's very helpful in pregnancy cases to time the infection.
Okay, that's useful. What about molecular tests, like PCR, detecting the parasite's DNA directly?
Molecular methods like PCR are great because they directly detect the organism regardless of the antibody response. PCR is proven highly sensitive and specific for diagnosing TE from CSF, for example, and the technology is widely available now.
Are there limitations?
Yes, sensitivity can be an issue depending on the sample type. PCR on CSF might miss some TE cases, for instance. So it's often used alongside serology. Real-time PCR can even give quantitative results, telling you how much parasite DNA is present. And you can even use PCR for genotyping, identifying the specific strain, which is useful for research and understanding disease patterns.
Okay, let's put this together. How would you approach diagnosis in different scenarios? Say, a healthy adult or child with just swollen lymph nodes.
In that case, if you suspect toxo, you'd test for IgM and IgG. A positive IgM strongly suggests acute infection. You might recheck it in 3 weeks. If only IgG is positive and stable, it's likely past infection. If results are borderline, you'd repeat the test in 3-4 weeks looking for a rise or seroconversion. Therapy isn't usually needed unless symptoms are severe or prolonged.
What about the much more complex case, an immunocompromised host, like an AIDS patient, suspected of having TE?
Right, this is urgent and complex. A presumptive diagnosis of TE is often made based on a combination of factors. The clinical symptoms, neurological deficits, fever, headache, a history of exposure, positive IgG antibody, and characteristic findings on brain imaging, CT or MRI.
How reliable is that presumptive diagnosis?
When all those pieces fit, the predictive value is pretty high, maybe around 80%. Remember, almost all, 97%, AIDS patients with TE have IgG antibodies. So testing all HIV patients for Toxoplasma IgG early on is crucial for risk assessment. IgM is usually negative in reactivation.
What do the brain scans typically show? And what are the pitfalls?
CT or MRI usually show one or, more commonly, multiple ring-enhancing lesions, often in the basal ganglia or the corticomedullary junction. MRI is more sensitive. But, and this is the big pitfall, these findings are not specific to toxo. CNS lymphoma can look very similar, especially if it's multifocal. Other infections can too.
So scans alone aren't definitive.
Not always, and there's but a 10% false negative rate. Interestingly, if there's only a single lesion on MRI, it makes lymphoma about 4 times more likely than TE, which might push towards a brain biopsy sooner.
How do doctors decide between biopsy and just trying treatment?
Often they'll do a therapeutic trial, start the patient on anti-toxoplasma drugs like pyrimethamine and sulfadazine plus leucovorin to protect the bone marrow. If the patient starts improving clinically within 3-7 days, it strongly supports the diagnosis of TE.
And if they don't improve?
If they don't respond or get worse by day 7-10, it makes TE less likely and points towards something else, usually lymphoma. At that point, a brain biopsy is typically necessary for a definitive diagnosis. PCR on the CSF can also be helpful alongside this process.
Does the scan improve as quickly as the patient?
Not necessarily. The clinical response is usually faster. Radiographic improvement on scans can lag by weeks or even months. Sometimes patients feel better even if the scan looks the same or slightly worse initially.
Okay, a very practical approach. What about diagnosing congenital infection in newborns?
The main concern is diagnosing it in the fetus if the mother gets infected during pregnancy. PCR on amniotic fluid is now the standard way to check for fetal infection. After birth, diagnosis in the newborn relies on serology, specifically looking for persistent IgG beyond what could be passively transferred from the mother, or a positive IgM or IgA test after the first week of life,
Right after the first week.
to make sure you're detecting the baby's own antibody production, not just leftover maternal antibodies. IgG levels should be monitored over time. But remember, up to 25% of infected newborns might be seronegative initially and look completely normal, so thorough clinical evaluation, eye exams, brain imaging, and CSF tests are crucial.
And finally, diagnosing ocular toxo. Antibody levels aren't always helpful there either.
Right, serum antibody levels might not correlate well with active eye inflammation, especially in reactivation cases years later. Usually the diagnosis is made based on the typical appearance of the lesions on an eye exam, combined with a positive IgG titer, even a low positive. If the lesions look atypical, diagnosis is more presumptive.
Are there other tests for eye cases?
Yes, you can test antibody levels directly in the eye fluid, aqueous or vitreous humor, and compare them to blood levels, the Goldman-Whitmer coefficient. PCR on eye fluid can also be more sensitive than blood PCR. These specialized tests can help confirm the diagnosis in tricky cases.
That's an incredibly thorough overview of diagnosis. Now that we know how to find it, let's talk treatment. How do we fight back against Toxoplasma, starting with congenital infection in newborns?
For babies diagnosed with congenital toxoplasmosis, the standard treatment is a combination of drugs: daily oral pyrimethamine and sulfadiazine, along with folinic acid, also called leucovorin, to prevent side effects like bone marrow suppression from the pyrimethamine.
How long do they take it for?
Typically for 1 full year. In some cases, depending on the severity of symptoms, especially eye or brain inflammation, a corticosteroid like prednisone might be added temporarily.
What about treating the mother during pregnancy to prevent or reduce severity in the baby? Is that standard?
It's a bit more complex and practices vary. Some places screen all pregnant women, others don't. If acute infection is diagnosed in the mother early in pregnancy, an antibiotic called spiromycin is often used, primarily to try and reduce the risk of transmission to the fetus.
And if transmission is confirmed or infection occurs later in pregnancy?
Then the treatment usually shifts to that pyrimethamine sulfadiazine folinic acid combination for the mother. While large trials haven't definitively proven maternal treatment prevents all cases, it's hard to do studies with untreated groups. The evidence strongly suggests that treating the mother significantly decreases the severity of the disease if the baby does get infected. Many women infected early might opt for termination due to the high risk of severe outcomes, but for those continuing the pregnancy, treatment is offered.
So a year of treatment for the baby. What about healthy, immunocompetent adults who get symptomatic toxo? Do they need treatment?
If it's just lymphadenopathy, usually not. Unless the symptoms are really severe or persist for a very long time, specific treatment isn't typically needed as it's usually self-limiting.
But what about ocular toxoplasmosis in healthy people?
That's different. Ocular toxo is usually treated, typically for about 4 to 6 weeks. The standard regimen is pyrimethamine plus sulfadiazine with folinic acid. Alternatives include combinations with clindamycin or sometimes etivoquone or TMP-SMX. This should always be managed in consultation with an ophthalmologist.
Is treatment always necessary for eye cases?
It's generally recommended, especially if the lesions are severe, large, or located near critical vision areas like the macula or optic nerve. While some mild peripheral lesions might resolve on their own, the risk of vision loss often warrants treatment. For patients with frequent recurrences, long-term suppressive therapy, often with TMP-SMX, can be considered to prevent flares while they're on the medication. Whether treatment improves the ultimate long-term visual outcome is still debated.
Okay. Now, the most critical group, immunocompromised patients. Treatment is life-saving here, right?
Absolutely. Acute toxoplasmosis, especially TE, in immunocompromised patients, is rapidly fatal without treatment. Before ART, these anti-toxo drugs were mainstays of survival, despite potential toxicities. ART has dramatically reduced the incidence, but TE remains a major threat, particularly in resource-limited settings where HIV is often diagnosed late.
So preventing the first episode, primary prophylaxis, is key. Who needs it?
Any AIDS patient who is Toxoplasma IgG positive, meaning they have latent infection, and whose CD4 count is below 100 cells/joule, should receive primary prophylaxis.
What's the best drug for prophylaxis?
The preferred regimen historically was pyrimethamine plus dapsone, but TMP-SMX, trimethoprim sulfamethoxazole, is now very commonly used and highly effective. The same dose used to prevent PCP pneumonia, usually 1 double-strength tablet daily, also protects against TE. It's often more practical and accessible, especially globally. If TMP-SMX isn't tolerated, other options include dapsone plus pyrimethamine plus leucovorin or atovaquone. Monotherapy with just dapsone or pyrimethamine alone isn't considered sufficient.
What if a patient is seronegative initially?
If an AIDS patient is Toxoplasma IgG negative and their CD4 count drops below 100, they should be retested. If they've seroconverted and become IgG positive, prophylaxis should be started.
Can this primary prophylaxis ever be stopped?
Yes. Once a patient responds well to RT and their CD4 count rises and stays above 200 cell for at least 3 months, primary prophylaxis can generally be safely discontinued. This reduces pill burden, side effects, and costs. But it needs to be restarted if the CD4 count falls below the 100-200 threshold again.
What about secondary prophylaxis, preventing recurrence after someone has already had TE?
Anyone who has been treated for TE needs to continue on maintenance therapy or secondary prophylaxis indefinitely unless their immune system recovers significantly with ART.
What's a threshold for stopping secondary prophylaxis?
Similar to primary, but maybe a bit more stringent. They need to have completed their initial TE treatment, be asymptomatic, and have a sustained CD4 count above 200 cell for at least 6 months on effective RT. A repeat brain MRI might also be considered. If these criteria are met, secondary prophylaxis can often be stopped.
And the drugs are the same?
Usually the same combination used for initial treatment, like pyrimethamine, sulfatazine, leucovorin, or alternatives like pyrimethamine clindamycin or TMP-SMX, often at slightly lower maintenance doses. And again, if the CD4 count drops below 200 later, prophylaxis must be restarted.
That's a clear strategy. Finally, let's talk prevention for everyone. How do we avoid getting Toxoplasma in the first place? Break that chain of infection.
Prevention is key. Simple measures can make a big difference. The two main pillars are avoiding undercooked meat and minimizing contact with potentially infectious cat feces, oocysts. HIV-infected individuals especially should receive counseling on these sources.
Let's get specific on food safety. Cooking temperatures.
Yes, the USDA guidelines are helpful. For whole cuts of lamb, beef, pork, venison, cook to an internal temperature of 145 degrees F, 63 degrees C, and let it rest for 3 minutes. For ground meats, it needs to be hotter, 160 degrees F, 71 degrees C. Poultry needs to reach 165 degrees F, 74 degrees C. Using a meat thermometer is the best way to be sure.
What about non-meat food precautions?
Wash hands thoroughly after gardening or any contact with soil. Wash all fruits and vegetables very well before eating them raw. And avoid eating raw shellfish like oysters, mussels, or clams, especially from potentially contaminated waters because they can concentrate oocysts.
Okay. And the cat connection. What's the practical advice for cat owners, especially those at higher risk like pregnant women or immunocompromised individuals? Do they need to get rid of their cat?
No, absolutely not. This is a really important message. Patients do not need to give up their cats or have their cats tested. The focus is on managing the litter box safely.
How should the litter box be handled?
It should be cleaned or changed daily. This is crucial because, as we said, oocysts only become infectious after 1 to 5 days in the environment. Daily cleaning removes them before they sporulate. Ideally, someone who is not pregnant and not severely immunocompromised should do this task.
And if the patient has to do it themselves?
They should wear disposable gloves and wash their hands thoroughly with soap and water immediately afterwards.
Any other cat-related advice?
Keep cats indoors if possible to prevent them from hunting potentially infected rodents or birds. Avoid adopting or handling stray cats, especially kittens. Feed cats only commercially prepared dry or canned food or well-cooked table scraps, definitely not raw or undercooked meat, which could infect the cat itself.
That sounds very manageable. Good news for cat lovers. Any other prevention points? Blood transfusions? Pregnancy screening?
Ideally, blood for transfusion into seronegative, severely immunocompromised patients would be screened for Toxoplasma antibodies. But this isn't routine practice everywhere. For pregnancy, seronegative women, especially those with high-risk exposures like owning cats, gardening, eating undercooked meat, should discuss potential repeat screening during pregnancy with their doctor. And generally, everyone, but especially HIV-positive individuals, should adhere closely to all these food safety and hygiene measures.
Wow, okay. That was an incredibly detailed journey through Toxoplasma gondii. We've really covered the ground from the basic definition of this obligate intracellular parasite through its complex life cycle involving cats and cysts and oocysts.
Right, its global spread, the different ways it's transmitted, undercooked meat, cat litter, contaminated water, even transplants congenitally.
Exactly. And how it actually causes disease, the pathogenesis, the pathology, and different organs like the brain, eyes, lymph nodes. Then the intricate immune response, how our bodies fight back, and what happens when that defense fails.
And the varied clinical pictures, from totally asymptomatic to swollen glands, severe eye disease, or life-threatening encephalitis, especially in immunocompromised or congenitally infected individuals.
Plus, the detailed diagnostic strategies, serology, PCR, imaging, even therapeutic trials, and the specific treatment regimens for different situations, including the crucial role of prophylaxis.
And finally, those practical prevention steps everyone can take.
So what does this all mean for you, the listener? This deep dive really shows how one tiny parasite can have such a massive, varied impact on global health, often silently. It highlights the incredible detail needed in medicine and public health. Understanding it to this level, mastering it, like the experts, really reveals these intricate connections between us, our environment, and the microscopic world.
Absolutely. The level of adaptation by the parasite, the complexity of the host response,
Yeah.
it's a constant interplay.
Mhm.
And understanding that interplay is key to managing and preventing the disease effectively.
And maybe a final provocative thought to leave you with. We touched on that controversial but fascinating hypothesis linking chronic toxoplasma infection to neuropsychiatric conditions based partly on those rodent behavior studies. Makes you wonder, doesn't it? What other subtle long-term effects might common, seemingly quiet infections have on our brains, our behavior, our mental health that we're only just starting to glimpse?
It's a huge question. This deep dive into toxoplasma shows that even with well-studied pathogens, there are layers of complexity and potential long-term consequences we're still uncovering. The dance between host and parasite holds many more secrets.
Definitely keeps the curiosity sparked. Thanks for joining us on the Deep Dive.